drug cause, type 1, group 1, very rare. So no one invented the PA catheter for that, all right? PA catheter was invented so that we could more accurately assess the filling pressure to the left side. So, we are though in an artery, which means you get a PA systolic. You get a systolic number here. You get a diastolic number here. It's in an artery. But the key function is that we get a pulmonary artery occlusion pressure or a pulmonary capillary wedge pressure. Because it's anatomically impossible to feed a catheter all the way over into the left atrium. Be a bad idea, creates PFOs and such. Not a good plan. Would you agree? So, if we have a catheter that can easily sit in the right atrium and we can't make it across that pulmonary capillary bed into the left atrium, the best that we can do is pressurize that pulmonary capillary bed with a wedge pressure. And so your pulmonary artery occlusion pressure or your pulmonary capillary wedge pressure, that is the filling pressure to the left atrium. CVP is your filling pressure to your right. Wedge pressure is your filling pressure to your left. We're trying with the right side, with their CVP, we want to know what's filling the RV in order to be sent into pulmonary circulation. So we want a left atrial pressure to see what's able to fill the left ventricle to be sent into systemic circulation. And of course, because it's an artery, we get a map here, okay? But just for clarity's sake, instead of calling it a mean arterial pressure, we call it a pulmonary artery mean. It's just backwards, okay? You got a map, you got a pen. So, I do think that it is important before we cover waveforms that we do cover the anatomy of this. So my off-site educators, this is the time to get out your swan and just kind of follow along with me. I'll try to be very, very clear about what it is that I'm pointing to and looking at, and then my guys in the room, I'll pass it around so you can touch it, okay? So, at its tip, you have a hole. You have a hole and a sensor. That hole, as this is a pulmonary artery catheter, is sitting in the pulmonary artery. That hole, that lumen, will be attached to the yellow lumen. Well, that's handy because on your monitor, your PA pressures are yellow. This is going into the PA, and so it's yellow, okay? Fisher Price. Now, I said that the most accurate way to assess your SpO2 is to come directly from the pulmonary artery after the blood has mixed with the coronary artery blood. So you do need to access this port. It is my preference that you have a three-way stopcock on it. However, boy, sweet Nancy Nooner, she will try. Okay, she'll try to get everything done for you, all those tasks. But if you leave what I call an invitation, an IV hub here, that's an invitation for sweet Nancy Nooner to put drugs there. Do we infuse drugs into an artery? No. So, sterile cap on your three-way stopcock here. Because you do want to access it for your SpO2, this is where we will draw that value. But this is not to be set with an IV hub, okay, with an access hub. Again, that tip is also where you get your SpO2 continuous monitor. That is going to be hooked to this little blue guy here. Again, light oximeter. Right behind that lumen opening is the balloon. Alright? So I'm inflating the balloon, that guy right here. That is how we wedge it into place. That is how it is pulled and wedged up against vessel wall till it can't go anymore. That's how it's wedged into place. But we're in an artery, we're traveling through. This is a blown up balloon that gets stopped on vessel wall. So that's a pulmonary embolism. Would you agree? we always inflate it. We are only inflating the balloon to wedge it into place, obtain that value, and then it's gone, okay? It stays in that area, but the balloon stays deflated. The safest way, therefore, to treat this is first and foremost to know that that balloon lumen is your red port, all right? Red port denotes it's very important. Pay attention. Red port is the balloon port. Now, you just saw when I inflated the balloon, when I pushed air into that lumen, it blew up the balloon membrane. So, if I take this syringe off, am I offering any infective risk to this patient? I don't think so. Not unless that balloon is ruptured. Not unless I take my mouth and blow in it. I know it's tempting, try not to, okay? But no, you are not giving any infective risk to this patient by removing this syringe. And it does have to be a very special syringe, guys. Take a look at the syringe. It is called a monojet syringe. It's written on there. And it has catches at 1.5 cc's, making it so that no matter how hard back you pull, you can't go farther than that. So that you can't overinflate that balloon, okay? Which would cause it to pop, which could pop a pulmonary artery. Talk about ruinous shift, okay? So, you'll also notice on this red lumen, there is a locking mechanism. There is a way to move this little piece here, which will lock this lumen. And I know that some of you have been taught to keep it locked. But let me tell you what happens if you teach an entire group of nurses, an entire group of clinicians to keep it locked. Someone inevitably will forget or not even know how this works, okay? And if you teach them to keep it locked and they come in and see, oh no, it's not locked and I'm supposed to keep it locked, they will just go ahead and lock it. And what happens to the balloon? It sits and stays inflated. And what did we say this was? A pulmonary embolism. So it's just creating club platelet right now, and you're going to get a PE, a true PE. So, if I unlock it, watch what happens to this syringe. It passively backfills every single time. So, and we know disconnecting it doesn't offer infective risk. So the safest way to treat your swan is to ensure that you assess your red lumen. It has the proper syringe. Remove the syringe, evacuate the air, put it back, and ensure it is unlocked. The swan should remain uninterrupted. Red line is uninterrupted equals unlocked. This way, nobody can accidentally wedge it, but air will not get trapped in there for any reason. Because no matter what, I have to have positive pressure on this syringe to inflate this balloon. If I take this off, the air goes straight out, okay? Uninterrupted equals unlocked. You also have measurement markings on this guy here. So the skinny line is denoting 10 centimeters. So this is 0, the tip is ground 0. Then I have one skinny line here, that's 10. Our thermal filament we talked about, he's covering 20. 3 skinny lines, 30. 40. And then you run into one thick line, 50. All right? Then it gets like Roman numerals. There's a fat line and a skinny line, 60. So, because we can manipulate this within a patient, there is risk that it could move. So every time we ambulate the patient, they can absolutely walk with a swan, maybe don't do cartwheels, but they can ambulate with a swan, it's fine. Or we're giving and getting a report. We need to measure where it exits this hub, all right? And it is an estimate. So right here, I see one thick, one little line. That is, I am staring at the number 60. And I know zero's over here. So, zero's inside the patient. I'll say this is 54, 55. Alright? But if Ben says, it was 62 earlier, that's different. If Ben says, I put it at 54, and I say it's at 55, no. Right? It is an estimate, but you do need to get comfortable with this. It does go all the way out to 2 thick lines, which is 100. Now, if it's measuring at 100, please check their rear end. That's where it's coming out. Ain't nobody's got it down at 100. You're talking 45 to maybe 65 at the very most is where it should be. Then, right around that 30 mark, you have 2 ports that empty right around there. Number 1 is your right atrial port or your CVP port. It's blue on here because it's blue on the monitor, Fisher-Price. I am fine with a 3-way stopcock here that has an IV access port because in the event of an emergency, I don't care what your CVP is. Let's just push the epi. Let's just slam the blood. I can rely on this going to the right spot. Okay? But this is not for your electrolyte replacement. This is not for your insulin drip. None of that business. This is an emergency port if you need one. Okay? You also have here the white lumen. This is your VIP. It's also called, if you read on there, your proximal infusion port. All right? So keep your very important drips here. It is my preference that we put a manifold with a carrier always. If they didn't come with any drips, they came to the ICU, don't worry, they'll probably buy 1 or 2. Let's just be ready. And only having your inotropes and pressors on here is what is going to keep them safe. Okay? So a carrier and just your very important drips. You typically have this headed through a multi-access catheter anyway. Use these ports for whatever your little heart desires. Okay? You need to give vent? Fine, give it there. You need to add an insulin drip? Fine, give it here. These can be used just like any other central line. You also need to be assessing the swandum or the sterile sleeve, whatever you want to call it. This does make it so that we could manipulate this within the patient. Okay? So this needs to be intact, no bleeding with inside of it, no condensation, no nicks or cuts. If that is the case, we would not be able to reposition the swan if it comes out of place. And then the other pieces to it, these 2 white and blue sides to it, this is what hooks into your continuous cardiac output monitor. Just be careful because you really have to screw it up. It's white to white, blue to blue. But if you bend any of the components inside of there, the whole catheter is broken. So don't do that. Now, I'm gonna need this for the explanation here, but I'll let y'all play with the balloon. Y'all can load up with the balloon and all that. So that was the anatomy of the swan. So let's look at the waveforms we get from this guy as it's headed into our lung vasculature. So they typically drop a sheet and then they feed this yellow piece in through there. On the monitor, it's not going to look all color-coded and pretty, okay? It's all going to be yellow, but lucky you just memorized what a CVP waveform looks like. Good job. And you will see that right atrial waveform show up. I know it's in the right atrium because of that waveform, so it does make sense that you should commit that to memory. And I know because the pressures are pretty low. Now, I know your textbook says 0 to 4, but I triple dog dare you to call up. Here we have Dr. Perrott as our CV surgeon. Somebody call up Perrott and ask if 0 is okay. Willing to bet he's going to hang up on you. So, in your CV world, we're talking, 4 to 8, 6 to 10 area, okay? That's how I know it's in the RA. Then they will say balloon up. If you're putting it at the bedside, you get to inflate the balloon because you're not sterile, okay? So, with a very kind of slow, concentrated effort, don't slam it, don't throw it in there like that. You just need to kind of push it in slowly and gently. you will inflate the balloon. You will put that plunger down. When that happens, it will be pulled by the blood into the right ventricle. In the right ventricle, which is a windy little ventricle, right? If it tickles the side wall, it's going to cause VTAC. So it's not safe to sit in the RV, but you will see a very ventricular waveform pop up. This is because when you're in a ventricle, you see that systolic force, the squeeze, and you're in a ventricle. So it squeezes almost everything out. There's almost nothing down there, right? In the diastolic phase, it squeezes almost everything out. So you're talking pressures in the realm of 25 to 35 millimeters of mercury over 0 to 5, okay? Balloon is still up and it will travel past the pulmonic valve into the pulmonary artery. Now you are in an artery, so you get an arterial waveform. You get a systolic, you get a dicrotic notch, the closing of the pulmonic valve, and you get a true diastolic number because it's a vessel. It's not squeezing everything out. So you get a true diastolic number. The systolic is largely close to the same. So 25 to 35 over teens. This is the only waveform acceptable for a pulmonary artery catheter. But the balloon is still up because we're trying to float it into place. So it will continue its path until it is wedged up against pulmonary artery and stops moving. Once that happens and it is wedged into place, it basically is pressurizing that pulmonary capillary bed so that it can see into the left atrium. We take this value after they have exhaled all their air, meaning their chest pressure is normalized to atmospheric pressure. So at the end of exhalation, we get a pulmonary capillary wedge pressure, or our assessment of the left-sided filling pressure. And that number is typically 6 to 12, 8 to 15 range. Notice that's higher than your CVP because we are on the high pressure side of the heart. So look at this. We travel from that low pressure side into that high pressure side. Once we gather that information, we can't keep the balloon inflated, so you let go. The balloon deflates, and then it goes back to that pulmonary artery waveform. Again, the only acceptable waveform. If you come in and you see that it is wedged, your first intervention is make sure this puppy's unlocked and take the syringe off. If that doesn't fix it immediately, it could be what we call permanently wedged, i.e. so far into that pulmonary artery that it is in and of itself wedged up against vessel wall, and you don't know how long it's been there. It could have adhered, started to grow scar tissue, scab, adhesion to that pulmonary artery, worth more than your license to pull it out. So you call for a chest x-ray and get a provider in there to come withdraw it, because you could dissect a pulmonary artery by doing that. Talk about rulership. If you come in and it is in the RV, should you just push it forward? Well, that's not how you got it into place in the first place, so it seems like a bad idea. If you were to just manually push it forward, you could puncture through the right ventricular wall, again, ruining a shift, okay? So, your intervention, if it is right ventricular, is to pull it back. You're going to have to retract it back into the right atrium, so until you see that waveform there, and then you call the physician and say, hey, came in, it was in the RV, it's not safe there, it'll tickle and make VTAC, have a whole different set of problems. So I came in, it was in the RV, had to pull it into the right atrium. Do you want me to just take it out, or do you want to come refloat this one? What information are we really gleaning here? Well, with the right atrial pressure, we're getting the filling pressure to the right side. We're getting, is my heart getting enough fluid to continue to pump out good fluid? That's what we're getting. So the same thing is true for the left. With our wedge pressure, we are understanding, is the left side getting enough? but also, are they overfilled? You can see that there. And if a heart chamber is overfilled, either you are severely fluid overloaded or it's not ejected. So you can see that there. So, you can also see the relationship between the two. And like we said, right side is always the low pressure system, left side is always the high pressure system. Now, use common sense. If they come out of surgery and both my wedge pressure and my CVP are low, well, they're both underfilled, right? Both sides. So I gotta fill up the back. If I come in and see they're both high, well, I can't rule out biventricular failure, sure. Maybe they're not ejecting. Maybe they're both really fluid overloaded. It does add context to your clues though. If you are looking and you see a wedge pressure that is quite high, greater than that 15 area, and a normal CVP, that's not fluid overload, is it? That's that left side is not ejected. But switch it. If my right side, that low pressure system, is higher than that muscular high pressure system, that's not fluid overload either. That's my right side isn't working. My right ventricle isn't sending it to the left. Now, one thing to note though, is we can't wedge. Without a physician at the bedside, we cannot inflate the balloon. So then Karen, what did you tell me all that for if that's for nothing? Because we can trend our PA diastolic, you see how close that is? We can trend our PA diastolic to inform us of our wedge. Again, the surgeon's going to be real sweet to you. They're just so happy you're recovering their patient. And they call and they say, what's my patient's cardiac output, or how's my patient doing? You say, well, the cardiac output is this. And they say, what's the index? That's all they care about. And then they say, what are my PA pressures? And you say, oh, in the 30s. What's my PA diastolic? Because that's the information they're going to care about. So, why do they care about PA diastolic? Because it is a conduit for our wedge pressure. So, I will use that tube analogy again. In your PA catheter, we're going from the right atrium, through the tricuspid valve, through the right ventricle, past the pulmonic valve, and into this tube. Okay? Into this tube. And when we inflate that balloon and we occlude the flow in that tube, what it's really doing is pressurizing this pulmonary capillary bed, effectively moving the curtains so that it can see into the left atrium. So if the balloon is not inflated and the catheter is just sitting in there, then we have to take into account this pulmonary capillary bed. That balloon's real small. That's not a whole lot of pressure to have to overcome, typically. So, you just do simple math, all right? And if my first grader can do it, I bet you can too. So, all you need to do is think, PA diastolic minus 2 to 3 is equal to my wedge. Just take out that pulmonary capillary bed. 8 minus 2 equals 6. 15 minus 3 equals 12. Because look at this, guys. In diastole, my pulmonic valve is closed, my mitral valve is open, so from here all the way to that left side is just one long tube. The only thing in the way is that pulmonary capillary bed, and I'm betting you can do simple math. So, when you're making decisions, does this patient need fluid or not? Is this a gas in the tank issue? You'll need to be looking at CVP and your PA diastolic. look, I worked really hard on all these pictures that I drew y'all, but if you don't like them, there's the textbook version. Rude. But it just illustrates the same thing. That tube